TB and Leprosy Manager, Dr. Patrick Lungu, who took this session very personal and decided to present our didactic for this afternoon. Dr. Lungu, thank you so much for joining us.
Thank you very much, Chairperson. I'm happy to share with the network about DRTB and also to be part of the people who will be discussing the cases that we will share.
No, thank you so much. We are privileged to have you on the call. We are also privileged to have on the call some of our experts that will be joining us and helping us discuss these cases. In addition to Dr. Lungu, we do have Dr. Zico, and we are expecting to have Dr. Mateo, also Dr. Mwemba should be on the call. And then we will also have Dr. Linus Mwinga will be expecting to be on the call as well. And then we've got many others. We also have Dr. Alwyn Mwinga. I can see she's on the call as well. So all these are quite people who are vested in TB a lot, have done a lot of work. And it's an opportunity for all of us to learn something from here. I also want to recognize Mazabuka General Hospital. They have a very interesting case that they would like to share with us. And so Dr. Humphrey Chanda and team from Mazabuka will be sharing a little later after the didactic. And then we look forward to that presentation as well. We continue to recognize a lot of our districts that are connected in Kaoma district. I've seen Senga Hill in Northern Province. I've seen Luwingu. I can see the webbing at us. Thank you very much for connecting. And I also saw Isoka. We have Petauke. Just to mention a few, but everyone else, you're very much welcome. We are happy that you were able to join us this afternoon. And so without further ado, Dr. Lungu, would you like us to share for you, or you will share your slides?
Yeah, let me try to share from this end.
All right, thank you so much.
Okay. Because I'm trying to switch on my video.
Oh, okay.
Okay, great. Good afternoon, everyone, once again. As introduced, I'm Dr. Lungu Patrick, the National TB and Leprosy Program Manager here at the Ministry of Health. So I'm happy to share with you my presentation on DRTB. And today I'll focus more on case finding for DRTB, and so that it links up very well with the case that we are going to have. So I think these are some of the objectives that we're going to achieve at the end of this session. And in here, we're going to define DRTB. We'll also look at what are the risk factors for drug-resistant TB. We'll further move on to look at how can you make a diagnosis of DRTB. And I think that's the main core of today's presentation. Lastly, we'll look at how can we treat DRTB. I would like just to say before I start that I have no conflicting interests to declare. I think this slide that I'm sharing with you is a very important slide in that over the years, all of you agree with me that DRTB is a growing concern in Zambia. I do remember during my training when we used also to deny that there's no drug-resistant TB in Zambia some years back, and it's just a few years ago. Today, as a country, we have an estimated burden of DRTB of over 3,000 cases that are expected to be diagnosed each year. Just to share with you that in 2019, the estimated burden did stand at 2,700. Today, it stands at 3,300. So as a country, alongside that, we're also making huge strides and great progress in addressing DRTB. So just to share with you that over 41% of the previously treated patients are not tested for rifampicin resistance. I'm sure as we go down this presentation, you'll learn more why rifampicin as a core drug that you needs to be tested for resistance. I would like to mention early enough that rifampicin resistance is a very core drug for the treatment of drug-resistant TB. And also just some statistics that I would like just to share, that an estimated percentage of previously treated cases in this country, we expect that 18% of these are drug resistant. And where are we drawing these cases, these percentages from, or statistics? These are drawn from the last two, including with the third drug-resistant TB, of which before the year ends, we'll have some preliminary results, if not early next year. So we'll have new statistics with regard to drug-resistant TB. So this is a growth I was referring to, that as a country we have made. If you look at where we're coming from 2013 to date, we're only detecting 79 cases in 2013. Last year, we detected 627, and 515. The previous year, it was 627. This year, as of last month, we had over 500 cases of DRTB detected. And this is against a target of 722. Why this slide is important is also linked to today's presentation, that we need to match up our efforts because our targets are huge. By 2023, we should be detecting over 2,200. These are the targets that we are challenging ourselves to achieve. And this is not actually 100% detection, but due to our given circumstances, this is what we are likely to achieve, or this is what we find fit as possible achievements. So we've been talking about DRTB, drug-resistant TB full. What is it? So it essentially is where you have—
Dr. Lungu, sorry for interrupting you. I was hoping we could do some pause.
Okay.
Is that okay?
That's fine.
Okay, all right. So I'm going to share. Okay, so I hope we're able to see that those polls that have been presented, and we're inviting people to participate. So the first question is, the following are high-risk patients for DRTB. The following are high-risk patients for DRTB. Relapse and return after loss to follow-up without recent treatment failure. B, patients who remain sputum smear positive at month 2 or 3 of first-line anti-TB regimen. C, treatment failure with isoniazid, rifampicin, ethambutol, and pyrazinamide smear positive at months 5 or later while on treatment. D, all of the above. So we are inviting you, all those that have connected. We have about 177 connections, and we want to hear from you. Which of the following are high-risk patients for drug-resistant TB? So we can pick which one is the best answer of all A, B, C, or D. I see many people are going for D as the best answer, but we're learning, we'll see, because one of the objectives for this session is to find out what are the risk factors. And so, and I hope that we've got this one right. So I will end the poll here. It's been close to 2 minutes for this session. So let me just close the poll. I will share just to show everyone how we have voted. So most people thought it was D. We still have a few people who thought A, B, or C. So the next poll questions that I'll share is a bit tricky, and I hope we'll be able to share this. So which of the following is not among the current recommended treatment regimen? Which of the following is not among the current recommended treatment regimen? There's A. It's difficult for me to go through all those letters. We can just speak from that. There's A, there's B, and then there's C. Dr. Lungu, we don't know these initials.
Oh yes, actually we're going to print some IEC materials so that people we can make life easier for the frontline healthcare workers. So essentially, these initials stand for drugs. KM stands for kanamycin, MFX stands for moxifloxacin, CFZ stands for clofazimine, and ETO stands for ethionamide. And ZPZ, I think everyone is familiar with E, that's the ethambutol, and HHD, that's the high dose.
Okay.
And what may be new to people is BDQ. That's one of the new drugs that we adopted 2 years ago. That's bedaquiline.
Okay.
Yeah, so interesting results already.
Yes. Yeah. Okay, so I know a lot of people have shied away from voting this one. We only have about 65 people that have decided to commit to one of these, but it's understandable. We will learn today. So I'll end the poll here and just share the results. So most people think it's A, a few think it's B, and while others think it's C. Just one more poll, and then we will move on to the main didactic. The next poll, I'm anticipating a lot of people to participate in this one. So the third poll is that in patients with HIV and MDR and rifampicin-resistant TB, treatment of HIV is different compared to those who do not have MDR or RRTB. B, there is drug-to-drug interaction between bedaquiline and NNRTIs. ART is recommended in all HIV positive who have MDR, RRTB requiring second-line ATT irrespective of the CD4. D, both B and C are correct. So our attendance has gone up to 207 connections, and already we have over 70 people who have actually voted. Okay, so this is very good. Most people think D is the correct answer. Anyway, we will see and pick up from the end of it. So I'll end the sharing and then, sorry, the pause and then share, see how people have done. So that's how we have done and that's how we have performed. So Dr. Lungu, I will hand back over the reins to you. You may take us through the rest of the presentation.
Thank you very much, Chairperson. And very interesting answers we are seeing so far.
Yeah.
And it forms the basis why we are here, actually.
Okay. Now you've moved a few slides ahead.
Yeah, I'm so sorry. Let me just move back. So, ladies and gentlemen, this is where we were before the poll questions. And I just have appreciated the answers so that I also emphasize some of the key points. So this is what we mean by drug-resistant TB. It's essentially a TB bacteria that is resistant to the core TB drugs, and which are isoniazid and rifampicin. So there are different classifications of drug-resistant TB. So other than the two drugs I mentioned, any resistance to any of the TB drugs is termed DRTB. I'm sure you have seen that I've refrained from using the term multi-drug-resistant TB and using more of the term DRTBs, because any resistance to the TB drugs is significant. And I would like just to go through some of the terms that are very, very important. And here we have mono-resistance, poly-resistance, and the common term we use, MDR. So mono is essentially resistance to one of the TB drugs. Then poly is two drugs. And then multi refers to at least resistance to rifampicin and isoniazid. So whenever these are there, it is multi-resistance. The other forms of resistance that you ought to know is XDR, which refers to extensively resistant TB. And here we have resistance to the injectables, and in particular, we're referring to amikacin. We're no longer using capreomycin and amikacin, so they have fallen off this definition. And also resistance to the fluoroquinolones falls in this category. And the reason it is so, because these are key drugs. Initially, the injectables formed the core drugs, but they have since dropped off, but the fluoroquinolones have maintained. WHO has maintained the second line injectables in the definition of XDR for some reasons. I'm sure maybe in the future they will revise this. Pre-XDR refers to where there is only resistance to one of the second line drugs, and in particular, we're referring to the fluoroquinolones, which are moxifloxacin or levo, or one of the injectables. And in particular, here we've only made one with one injectable in our regimen, which is amikacin. And where we have XDR, our total resistance, is where you have, it is difficult actually to constitute a regimen. There are cases of this nature. Zambia, we haven't detected such a case yet, but I'm sure if we look carefully, there may be one case. This is very, very important, ladies and gentlemen, for us to understand the subject we are discussing today. So what this algorithm shows that you could actually acquire drug-resistant TB in two ways. One of the ways is that you acquire drug-resistant TB while on treatment. And here, this is what we refer to exposure to the drugs. And this comes as a result of underdosing. It also comes as a result of poor adherence, factors that have to do with poor intake of drugs. Then the other thing that you should be highly concerned about is the primary drug-resistant TB, which we are seeing to be on the rise, if not in significant numbers. Here, we are referring to an individual who has never suffered from TB. And the first form of TB they develop is drug-resistant TB. From the statistics that we have, this accounts for at least 40% of our DRTB. So it's a huge concern that we are having such a significant or a huge proportion being primary. What this starts to tell us that there is a lot of community transmission, not only community as well as nosocomial transmission. And it is for this reason that we should all pay particular attention to infection prevention, both at community and national level. And this also forms part of the case that we are going to discuss. You will see that we have a child, not to preempt the discussion, is that we have a case of a child exposed to a DRTB patient, and they have TB, and that in itself is primary TB. So I mentioned in the objectives that we'll look through some of the risk factors. As you saw in the poll question, any form of treatment failure for TB is a risk factor for TB. That patient should be flagged as a high risk patient for DRTB. You've seen that I've decategorized my presentation here. I'm not putting about high risk, low risk, medium risk. For me, any of these risk factors is high risk. And it is for that reason that I've not put that categorization. A close contact of a DRTB, when they develop TB, that patient is likely to have DRTB because the form of infection they have gotten is from an MDR patient. So in that regard, this patient should actually, you will see when we go to treatment approaches, that this patient will be treated as a DRTB patient. A loss to follow up on the treatment regimen, this is a high-risk patient. HIV patients, and the reason here is a drug-to-drug interaction. Patients from facilities with high DRTB rates. This includes prisons, healthcare workers fall in this category. Children who are close contacts, this we have already talked about it, and actually we are going to discuss this in a lot more detail as we discuss the case. The other risk populations of interest, I want to talk about the comorbid conditions where there is malabsorption or where there is rapid transit diarrhea. And the reason for this is that the patient, after taking the drugs, they quickly pass out the drugs and only small amount remains in the body. And it is easy for that individual to actually develop resistance. So malabsorption, any form of malabsorption, and be it hyperemesis, which is not a malabsorption, but any other condition such as hyperemesis, can too also lead to DRTB. So those patients with hyperemesis are a risk factor for DRTB. And these are individuals who are on treatment and they have recurrent vomiting. So those individuals should be flagged off for DRTB. So how does DRTB present in terms of the clinical presentation? I'll share with you that it's difficult. Actually, there is no clinical feature or symptom that is pathognomic of DRTB. So you will not be able to distinguish from the symptoms or the clinical findings, even the chest X-ray findings, between drug-sensitive TB and DRTB. And also you could even have DRTB presenting as either pulmonary or extrapulmonary. And we have cases that are on treatment or have been on treatment that were DRTB and they were extrapulmonary. So in essence, from the clinical aspect, you cannot distinguish in terms of the presentation, but a high index of suspicion is highly required based on the risk factors. So in terms of diagnosis, we should be glad that we have the molecular tools as well as the phenotypic tools as well to confirm or exclude DRTB. So this essentially, what we're saying is that we have the laboratory means to confirm or exclude DRTB. And the tools that we have are the GeneXpert, the line probe assay, and the culture, both liquid and phenotypic. I'll not go through the different molecular modalities, but they are here outlisted. So in terms of phenotypic, this is where we use culture, and you either use solid or liquid. I'm sure that our lab colleagues appreciate this. I'll not go into much details about these modalities, but I think clinicians, you ought to know that there are two modes of confirming DRTB using culture, which is solid culture, and liquid culture. So it's very, very important that we all know how to interpret the results. So it all starts by having a presumptive TB patient or a presumptive DRTB patient. And once we get either the expert results using any of our any of the symptoms available, be it sputum, CSF, aspirate, or stool, or even an effusion as well. So the results that will come are either MTB detected and reef sensitive. And in that regard, that's what you're dealing with, is drug sensitive TB. And when the results show MTB detected and RR detected, what this now means is that you have a patient with drug-resistant TB. There are some cases, I think this must be known here, that there are some cases that will come MTB detected but RR sensitive. This does not exclude drug-resistant TB, because the gene expert is only limited to detect able to detect other forms of resistance such as isoniazid. And it is for this reason that patients we are suspecting to have drug-resistant TB should be subjected to a line probe assay, which is the LPA, and culture with full DST. I also want to emphasize that all relapse cases and all patients who are failing treatment, their specimens must be subjected to culture and the full DST, because you'll be able to pick up other drug resistant other than rifampicin, which the gene expert gives us. We now move on to treatment. I think we need to appreciate that it's of paramount importance that a patient detected with DRTB is quickly linked to care and quickly initiated on treatment. And the reasons are that we want to achieve cure, and also we want to stop the chain of transmission. DRTB is as infectious as the drug-sensitive TB. These goals must be known by all of us, and we should also ensure that this is done. The other goal that we must ensure that is done is that the patient with DRTB must be started on an appropriate therapy. So a drug history must be collected, and also you must have a resistance profile of this patient or a resistance profile of his or her contacts. And this is where our colleagues from the lab come in, that we need to have a good profile on patients in terms of their resistance or drug sensitivity for us to initiate appropriate therapy. Time and again, we start to realize that these patients have other forms of resistance other than rifampicin when they have already been exposed to other drugs, meaning we are weakening our regimen. Even those other drugs that may have been sensitive, we risk or we may end up losing their sensitivity. So it's very, very important that we prioritize and put critical attention to DST or to specimen that we receive. Ladies and gentlemen, I would like you to appreciate the drugs that we use in DRTB. Things have changed, and we now only have 3 groups. Initially, we used to have 5 groups, 1 up to 5. Now we have A and C, and they are here classified as A, B, C. And I would like just to share with you that the core drugs in this regimen are the group A drugs, which are your levofloxacin or your MOX, and bedaquiline being a key, and the Nasolid. So when constituting a regimen, these are your first priority. You could pick 3 drugs from group A and a 4th drug from group B. Where you fail to pick 3 drugs from group A, you could pick 2 drugs from group B. In circumstances where you cannot constitute a regimen using A and B, this is where you fall on to group C to augment your regimen. So group C is actually used to either augment your regimen, or in circumstances where you have failed to constitute a full regimen from group A and B. I hope we are together. There are certain circumstances where you're going to fall on group C, and this is where you know the sensitivity patterns as well, where you realize that your PZ, your ethambutol are sensitive. But I would like to also just to share a little bit about ethambutol and PZ sensitivity. It's quite, from the lab side, if the lab colleagues are here, they will agree with me that sensitivity to PZ and ethambutol is not that reliable. And it is for this reason that even when they are sensitive, we'll still fall back on group A and B. Moving forward, ladies and gentlemen, the treatment options for adults and children above 6 years is that we could use I want to talk about the INH monoresistance. This is another form of resistance that we need to pay attention to. So in this regard, you're going to use your first line drugs. Unfortunately, we are unable to unbundle the 4-FDC. So what you just do in this regard is that augment your regimen with levofloxacin. So you will still give your 4-FDC, even if the isoniazid is resistant, and then augment that therapy with with levofloxacin, and the duration of treatment is 6 months. So when you encounter such, please, this is how you're going to treat the patient. Moving forward to MDR or rifampicin resistance, I think what you ought to know that the treatment duration is 18 to 20 months. This is what the nation has adopted. So the duration is that long, and the key drugs are your bedaquiline, levofloxacin, MOH, and clofazimine. Linezolid is also forms that of the key or core drugs, and you give this regimen for 6 to 8 months, depending on how they are responding to therapy. And after 6 or 8 months, you drop off your bedaquiline. So this, you must remember that bedaquiline, its duration of use is 6 to 8 months. There are exceptional cases where bedaquiline is pushed into 12 months, and this must be done with consultation with the experts or the clinical expert committees in your province and at the national level. The second option in terms of treatment is where you're using BDQ, MOX, clofazimine, and so essentially that's your regimen. There are certain circumstances where we're going to use a modified or oral shorter regimen. And this is a treatment of 9 to 12 months. So in this regard, you're going to still use your bedaquiline on a more prolonged phase. I'll need to amend the way I've presented this. So when you're going for a shorter regimen, bedaquiline runs for 9 to 12 months. So please understand this. So most of our patients are going to fall on the longer regimen, only a selected few. And here we look at clinical parameters to distinguish which regimen a patient will go on to. I would like just to just share with you that DRTB in children is quite challenging. Challenging from many fronts, in that it's difficult to constitute a regimen. Pediatricians will be up in arms to say levofloxacin affects the growth of the child and many issues. So childhood DRTB raises a lot of concern. And some of these drugs actually don't have appropriate dosing for children, or even the formulations may not be palatable to children. So this is why we should prevent DRTB or any form of TB at all costs, because it creates a lot of challenges in this age group. So in the age group between 3 to 5, the drugs to fall on are fluoroquinolones, linezolid, clofazimine, and cycloserine. Delanamide or PAS are an additional drugs that could be considered. In the age group below the age of 3, you bring in ethionamide and high-dose isoniazid as key options. But above the age of 6, bedaquiline can be considered in children, and if anything, should be or must be included in the treatment. Ladies and gentlemen, one of the things that I think we all ought to do is that we will have not treated a DRTB patient without contact tracing. Why do I say so? DRTB, just like susceptible TB, is an airborne. And one of it is one of the other key issues that we need to remember, that DRTB progresses a little bit slower than drug-sensitive TB. So by the time we actually have found the DRTB, this patient has infected other household members, as you will see in the case that we are going to discuss. So in the spirit of holistic approach, a DRTB contact tracing must be done. You will have not fully worked up a patient with DRTB by mere diagnosing, by mere commencement of therapy without doing contact tracing. It is very vital that we do a full household contact tracing. And in that approach, we should prioritize people living with HIV, pregnant women, and children. These must be reached out if there's any. The other issues as part of the holistic approach, nutritional support is very key in achieving great goals in DRTB. So one of the things that I wanted just to share with you, that as we conduct contact tracing, the beginning or the entry point is a history taking. And the history here, we are referring to the symptoms of TB. Physical examination must be done. Ladies and gentlemen, I've been visiting facilities. This is not on blaming everyone, but just to encourage the grassroots that we must endeavor and make an effort to do a physical exam. A full physical exam is very, very important in TB screening. The other issues that you need to look at are the risks. What are the risks of these individuals developing TB or DRTB? How long were they in contact? The HIV status of that particular individual. Is this patient pregnant? What is the occupation of these individuals? This must be highly considered. After that, now you go into now collection of sputum, and I'll still emphasize that a spot sputum is good, but not good enough. So where you could collect an early morning sputum, please do so. Because you may say this patient is not bacteriologically confirmed on a spot, yet someone has. The experience that we've had from the grassroots, it has taught us that an early morning sputum makes a huge difference in DRTB or TB diagnosis. So we should try by any means to collect both spot and an early morning sputum. A chest X-ray, ladies and gentlemen, has a very key role in TB diagnosis. If you compare the sensitivity of X-ray with that of sputum examinations, nothing beats the chest X-ray in terms of screening for TB. It's a very high sensitive tool, but not specific. The chest X-ray falls on specificity. Where you have an abdominal X-ray and a contact of DRT or TB, please, and if you have challenges in interpreting this X-ray, reach out. You could call 7040 and share the X-ray with that clinical expert who is there, and it will help you interpret the X-ray. We should not forget to examine the sputum by X-ray. In children now, you could actually even use stool. Only in adults, stool can only be used on unconscious patients. HIV testing, ladies and gentlemen, must be part of your contact tracing. But where people refuse, let's endeavor to cancel and continue canceling until they accept. TST or IGRA, where it can be done, please, let's bring it as part of the contact tracing approaches. And I'll emphasize where it can be done. And I've already talked about the use of stool in children. For those who may have questions on this, please, let's engage. Here, Chair, and ladies and gentlemen, I just wanted to share that we must pay particular attention to HIV with regard to DRTB. People living with HIV are at a high risk of drug-resistant TB. And for this reason, we must pay particular attention. And one of the things that we must endeavor and aim to achieve is that we must optimize on their HIV care. That we should aim to actually achieve viral suppression, and that way we will achieve our goal, which is a treatment success for DRTB. We must pay particular attention to drug-to-drug interaction. If barbarins does react with bedaquiline, and where possible, amend the DRT regimen so that it suits the DRTB regimen that Okay. Sorry, I got muted.
Sorry, Dr. Lungu. I think we got some really disruptive interruption. So please go ahead now.
Thank you very much. So you may also experience or note that some people living with HIV may experience some adverse effects, and this is due to multiple drugs. So we must pay attention to ADSM. And here ADSM, we are looking at adverse effects of both ART or the DRTB drug. So we must monitor these patients very, very, very closely. I think those are the things that we must pay attention to. So if anything, DRTB patients, clinicians, please let's pay attention to these patients. So in summary, DRTB is a growing public problem in Zambia. And I would like just to share that we have the screening tools for DRTB. We must expose sputum or any sample to gene expert and also culture as well. Our culture facilities are underutilized, so please, we should not end at just a gene expert, but go to every length to subject the specimens to culture and food drug sensitivity testing. People living with HIV are at an increased risk of DRTB. Another key point I would like just to mention is that primary DRTB is on the rise, and for us to actually bring this or reduce this is that we must do a lot of contact tracing. Remember this, for every DRTB patient that you are seeing in front of you, there are multiple others closer to this patient within the household or within reach of your index patient. Management of DRTB patients calls for a holistic approach, and in this, it calls for contact tracing. We should not be satisfied that we have put a patient on DRTB without conducting contact tracing. Patients with DRTB suffer a lot of psychosocial challenges, and they require our support in terms of psychosocial support. And this should run alongside the nutritional support. Ladies and gentlemen, DRTB is not a life sentence. We've changed the tides from a DRTB treatment success rate of 33% to now 76%. We are at the verge of the end of the year. From the information that we have is that we are likely to reach 80% treatment success rate. So therefore, DRTB is curable. Chair, I end my presentation here, and I thank you all for your pleasant listening. These are my contact details, so please feel free to reach out should you have any questions on my presentation or any questions with regard to DRTB. I'm at your service. Many thanks.
Very, very insightful presentation, Dr. Lungu, and lots of lessons that I've learned this afternoon. We appreciate your time to put this work together and just share with that network. I know this has added to our knowledge. So I think just to go over before we go to questions, I think maybe if you would allow me, we go through the poll questions so that our network may be we may understand properly some of the questions that that we had shared initially. So I'll start with the first poll question. And this one was on in patients with HIV and MDR-TB. Treatment of HIV is different compared to those who do not have MDR-TB. There is drug-to-drug interaction between bedaquiline and NNRTIs, and then ART is recommended in all HIV. Sorry, this one that I share, I think it's the wrong one. Okay, yeah, so this is the one that is correct now. So we are in, the first poll question is that the following are high risk factors for DRTB. And A says relapse and return after loss to follow-up without recent treatment failure. Then B, patients who remain sputum smear positive at month 2 or 3 of the first-line anti-TB drug regimen. And then C, treatment failure to isoniazid, rifampicin, ethambutol, and pyrazinamide, smear positive at month 3 or later while on treatment. And then D, all of the above. Dr. Lungu, which one here is the correct answer? I think we lost Dr. Lungu. Not sure if the network is okay with him. Okay, so I think Dr. Lungu may have just might be having trouble with the internet because he just disconnected. So,
we have lost power at MOH, so he should be connecting once power is back.
Okay, all right. Thank you very much. Thank you for that feedback. So what we'll do is that we are going to stop this one. We'll get back to it once Dr. Lungu and team are back on the call. So what we'll do for now is go to Mazabuka and ask them to present their case. I think that's how we're going to present. We're going to proceed so that we don't lose time. We've got a very interesting case. So I am going to share, and then we'll invite the team Mazabuka to share, to make the presentation.
I apologize. We lost power here, so I
Dr. Lungu.
Yeah. Was there any issues that I needed to address?
So no, not Dr. Lungu. So what we'll do is that I wanted to go through the pause quickly. Yeah. Maybe you could just run us through quickly. Here's the first poll. I don't know if you can see it.
Not at the moment. I think I'm seeing the presentation by Chanda.
Okay, let me just stop sharing. So, are you able to see the pause?
Not yet.
Yeah.
I don't know. For some reason, I'm not. Yeah, I'm able to see it now. So with this question, all the above were correct. So all the populations here discussed were at risk of DRTB. And I think over 91% had gone for answer D. So those who said all the above they are correct.
Okay.
Isn't it best to share results? Because we launched the rapidly.
Okay. No, I'm relaunching. So, Dr. Lungu, we had this other question here again.
Yeah, so with this one, I think this was one of the easiest questions in a way. Kanamycin, we've done away with it. And I mentioned this in my presentation. There's only one injectable drug that we have returned, that is amikacin. So A is incorrect.
Okay.
A is not the correct. So we've done away with kanamycin.
So which one of one is not correct? So A is not correct.
A is not correct, yeah.
All right, thanks.
There should be the last 4 questions. There were 3.
Yes. So here's the last 4 question. In patients with HIV and MDR-TB.
Yeah. So here B and C are correct.
B&C are correct.
In my presentation, I did refer to that efavirenz does react with bedaquiline, and for that reason, that answer is correct. C, ART is recommended in all HIV positive who have drug-resistant TB. This, regardless of CD4 count, this, ladies and gentlemen, we must ensure. And we should actually go an extra mile by supporting this patient so that they achieve viral suppression.
Thank you so much. I think those will come out in the next case that we're going to present. So yeah, we'll quickly move on to the next presentation. If you have any questions, I think they'll be cleared off as we discuss the next case. It's important that we have this case shared. So Dr. I don't know if you are on the call. Are you able to talk about this case here? Dr. Chanda Humphrey? We seem not to have him on the call. I don't know what's happening to the team in Mazabuka. I will ask Dr. Graham to pick it up.
Okay. Thank you, Dr. Ziambo. So I think the team in Mazabuka are having a bit of network issues there. Though Dr. Jackson, I think, is on standby to take you through the case. So it was the second in line.
Please,
in
Dr. Jackson, please go ahead. Go ahead. We're looking forward to this case. Just go ahead and share and take us through.
Okay, yeah. Thank you, Dr. Ziambo. I'll start a case. If once Dr. Chanda is able to join, he will pick it up. But I can see the team is not connected. So can you hear me? Yes, Doctor.
If it's okay, I can present using the phone.
Okay, go ahead, Doc.
Okay, just give us a minute. You mute the speaker there. Just leave. Or mute. Yeah. Hello?
Yes, Dr. Chanda, go ahead. We can hear you.
Leave. Just leave. Yeah, leave. Good afternoon, everybody. Hello?
Good afternoon, Dr. Chanda. Go ahead.
Sorry, we have a problem just as like last week. So I'm going to present the phone. Jackson, help me with the slides. So my name is Chanda Humphrey. I'm the HIV/TB medical officer at Mazabuka General Hospital. I'm here with the rest of the team as we present the case on MDR-TB. We have a case of a 13-month-old baby whose RVDR started on ART at 6 weeks of age. The baby presented to the hospital with a history of a chronic cough, body hotness, and poor weight gain. In the past medical history, this baby has a history of general ill health with multiple admissions for severe acute malnutrition in the pediatric ward, history of recurrent and multiple admissions for pneumonia and diarrhea since the age of 5 months at their local clinic. There's this of being treated for TB, which the client completed 2 months ago, that is prior to the admission at the general hospital. And also history of poor compliance to the TB medication. When we probed further to find the reason for this poor adherence, the mother, an 18-year-old single mother, said there was poor socio-economic status at home. So when there's no food at home, the mother will not give food to the baby. So that was the reason that she said. Then for the immunization history, the immunizations were not up to date as the mother stopped going for antenatal clinic after some months. For the drug history, there's history of being put on prophylaxis, that's AZT, 3TC, and lopinavir at birth. And at 6 weeks, when the baby tested positive, the baby was started on ABC, 3TC, and lopinavir. Then, as I mentioned earlier, there's history of being on ethambutol, rifampicin, pyrazinamide, and isoniazid. That was when the baby was diagnosed with TB early this year in January. On the social history, the baby lives with the mother and 18 other occupants at the home. And this is the house which is only 4-roomed. All the members of the family are not working except one. So there is likely of steady income at the household. As such, the family cannot afford the daily needs, including the meals that are needed in a day. Then there's also a history of the mother being diagnosed with MDR TB. This is while the baby was in the hospital. The mother was noticed to be having a cough as well as fever. While the child was being treated for pneumonia, we took a sample from the mother and we took it for gene expert, which came out as RR. At this point, the mother and the baby were referred to the chest clinic. And upon arrival at the chest clinic, the physical examination, there was poor nutrition status for both the mother and the baby. The baby had pallor, which was moderate. The baby was in mild respiratory distress. The oral cavity was clear. The baby was febrile to touch, and there was no lymphadenopathy noted. On the vitals, the weight was 4.5 kg, and the height 60 centimeters. The Z score was calculated to be less than -3. The BP was not done due to lack of pediatric coughs. The pulse was rapid and feeble at 136 beats per minute. The temperature was 39 degrees Celsius, and the baby was saturating at 92% on room air. On auscultation of the chest, there were crepitations that were diffuse in all the lung fields on both lungs. On the CVS, S1 and S2 were normal, and no murmurs were heard. Next slide, please. So these were the labs that were done on the baby. Upon the first contact on the clinic, a DBS was done on the 30th of September 2019, and it came out as not reactive, and the decision to repeat at 6 weeks was made. And at 6 weeks, when the test was done, it came out as positive, and the repeat and confirmatory test as well for the DBS came out as positive, and the baby was started on ART, which is ABC, 3TC, and lopinavir, as well as started on cotrimoxazole. The viral load, which was done last month at the hospital, when the baby presented to the hospital, it revealed a viral load of 119,000 copies per mil. At this point, the baby was enrolled in EAC. as well as the mother. Also, both the baby and the mother were enrolled in IAC. As blood was collected for CD4 count, unfortunately, for the past few months, we've been unable to do CD4 count at the hospital, and the blood that was collected was sent to the nearest hospital. We're still waiting for the CD4 counts. And at MCH, when we followed up to see if there was any CD4 done prior to the presentation at the hospital, we couldn't find any documented CD4. The GeneX part that was done, the first one was done on the 11th of January. This is the point at which the first diagnosis of TB was done, and the MTB was detected. Rifampicin resistant was not detected, and the baby was started on first-line TB medication and B6. But as we alluded to earlier, there was history of poor adherence, and so the baby presented 2 months after completing the first-line medication with fevers and all the B symptoms as well as malnutrition. So at the hospital, we did 2 MTB gene experts on the 15th and 18th. No MTB was detected. Please kindly mute your devices. Another sample was taken on the 20th of October. At this point, we were advised to do a stool sample. And these 2 samples also came out negative. However, the baby was still getting worse in terms of clinical terms. The weight was kept dropping, and the fevers never settled despite being on antibiotics and on first-line ATT. So at this point, a clinical diagnosis of MDR TB was made based on the mother's positive history, as well as the lab for the mother who was RRR. And so the baby was started on second line and tuberculosis treatment. She was started on levofloxacin, linezolid, clofazimine, and cycloserine, as well as B6. At this point, we also collected the sample for culture and LPA, as well as IGRA was also collected. For the full blood count, so Dr. Jackson, just before, you can go to the process. Thank you. The full blood count, what was done in August upon admission to the hospital, the HB was 8.7, with an MCV of 72.9, and the MCH was 23.3. So this was an anemia of a microcytic, hypochromic microcytic anemia, which can either be due to the chronic illness and also the TB. The ESR that was done was 120 millimeters per hour, and the differential count showed the lymphocytosis as well as the monocytosis. The baby was put on hematinics. The zero. The other parameters had resolved at this point. The chest X-ray showed the infiltrates in both lung fields, and also there was hilar lymphadenopathies. So this, at this point, also consulted with the TB focal point person here at the district, and also at the province and the national level, to help us interpret these results. So this was a concerted, as Dr. Lungu said, we shared extensively and consulted to arrive at this description of the X-ray. So this was the point at which the baby was started on MDR. The culture results that were taken on the same date, however, came back as contaminated. So we collected another sample, which we are waiting the results for. this sample, hopefully in a few weeks, we'll get the results. The sequencing test was done on the 21st of October, 2020. The reason for this is the history of sickle cell disease in the family. So that's why we did the sequencing test in this child. Next slide. To continue the history, as I said earlier, with the clinical deterioration of the child while on first line, and remember this child was bacteriologically positive in January without any improvement with worsening loss and the positive contact of the mother being MDR. A clinical diagnosis of MDR was made and the child was started on those drugs that are listed there. 3 days after starting the drugs, there was an improved, the fevers they settled and the appetite.
Sorry, Dr. Chanda, you're remaining with 2 minutes.
Okay.
So you might want to summarize very quickly.
All right, the case is very long, Dr. Koza. All right. So there was marked improvement in both the fever settled and the weight improved. This was the first time that this happened. On the last visit, the weight was 5.8 kg. That was from the previous 4.5 in a month. And then for this baby, also offering nutritional support, counseling to the mother on feeding the baby with nutritious foods that are locally available. We're also supplying and then for the rest of the family, there are 19 so far that we've managed to track, and 12 out of the 19 have been put on MDR TB treatment. While the rest are being followed up, we're still investigating the gene expert, the culture, as well as monitoring them clinically. And there's also a history of sickle cell in the family and mental illness. So this is just a graph to show how the weight has improved from the starting of the MDR treatment in October, and just showed an upward trend from the time the baby was admitted in August. This is a graphical presentation of how the family, so there's grandmother there and grandfather up. Yeah, that's the grandmother. And then the square, those are the males. So the grandmother was started on MDR. She actually came out RR positive. And then this is a first pseudo family. You can see 6 of them out of the 8 are positive. The index is on the far right. That's the mother to the case of presenting, and the case is there, who's 13-year-old, and the mother is 18-year-old. Both are improving. The black stars that you can see these are members with history of mental illness, which maybe because of time won't go in the depth of the kind of mental illnesses. And the yellow stars, those are families that have sickle cell disease. You can go to the next slide. Yeah, so this is a table just to show a bit more of detail for each of the family members that we're following up. It's quite a long list and I won't take time to go through, but the first person there is an index case. So this is the mother to the child that we're presenting, RR positive, and culture was done. However, there were no results for the drug sensitivity testing, but was started on the MDR treatment and she's doing very well. Then there's a history of defaulting. This is the brother to the mother. Sorry, not defaulting, but treated twice for TB with no improvement on first line. Again, we started, the patient has not improved. So it's a patient also evaluating for high risk of MDR. You can scroll down for me. The ones that are in that are highlighted, these came out as positive, and these are ones who started in MDR. There's an interesting case here. We have Lucky, who came out as the microbacterium other than tuberculosis detected, has a history of defaulting earlier this year on drug sensitivity TB that was diagnosed bacteriologically and defaulted, and then it came back. We did a culture and it came out as MOH. So I've started on ethambutol and azithromycin. There's another family member also who started on DSTB SS, the 31-year-old, And however, the client had completed DSTB 3 months ago with no improvements. So from what we've learned today, this is a patient with high risk MDR TB treatment. However, the samples we collected were, thank you, Dr. Jackson. Okay, so our questions, as you can see, this case is very loaded. We had at the facility a lot of questions. However, we cannot ask in the interest of time. So we just took those that we feel can be important to our discussion. And then later on behind the camera, we can discuss the other questions. So the next question is, what other panel of investigations can help establish the diagnosis of MDR TB, where quality sputum is a challenge to collect, such as in children? You saw from our presentation that despite doing several different kinds of investigation on this child, the results were coming out negative. It could be an issue of the quality of sputum or any other issue as contamination. So, but clinically we diagnose and the child is improving. Then the second question is, how do we ensure the child remains adherent on both MDR therapy and also ART? And if so, what are the drug-drug interactions that we should look out for? So remember, this is a child who's also failing on ART, with the last year was being almost 200,000, and also a child of a single teenage mother. So those are challenges that we should look for as we answer this question. Then the next question is, how can we improve on the turnaround time for samples that we send to laboratories for investigations, such as the first line and second line LPS in our MDR patients? So currently, right now, the turnaround time has improved. It used to be more than 3 months, now it's 2 months, but still not, we feel we can do better. And the samples are coming out as reported and lost or contaminated. So how can we improve? The fourth question is, what are the special considerations in managing clients with MDR TB and the issue of mental illness and sickle cell? We have 2 of the clients from the family who have got mental illness. One looks like a psychosis, the one is a depression, who are high risk for MDR, and we've got 6 of the members that are on sickle cell disease. So these are anemia, and some of the side effects of the drugs that are using MDR actually cause bone marrow suppression. Number 5 is, what interventions should we take to ensure infection prevention in this family of 19 that are living in a 4-roomed house? So this 4-roomed house is a cooking place, and then there are 2 bedrooms, and then there's a sitting room where people sleep miscellaneously. So there's a boys' room, the father's room, and the room for everybody. Then the number 6 question is, what TPT considerations can we make in the context of MDR? So there was a suggestion that perhaps those people that were still investigating, we put them on some form of TPT if they're not already infected.
Thank you so much, Dr. Chanda. I know I rushed you, but I think we were running out of time. We only have now 14 minutes to the end of this session this afternoon. So we will quickly go into our breakout sessions. I will not ask for clarifications, but we'll go into our breakout sessions. Southern Province, we will have Dr. Mwemba, who is on the call, and to support Southern Province as one of the experts. Then Eastern Province will have Dr. Linus Mwinga, and then Western Province will have Dr. Zico and Dr. Walubita take us through. So IT, please take us through. So in our breakout session,
They are switching.
Now as we'll break out in
How come they find space? Oh, it's overheating.
Any addition or subtraction? I haven't given me the process. Who requests it? Who authorizes it? I want the process. And we see who starts. Who is the second person? Who is the fifth person? On the card. Let's say, for example, TP. Never check it. Money has come under the roof. And malaria. Okay. So previously, what we used to do was what currently, what's happening now? Currently, we were trying using the electronic version system. Because apparently, when we request to do the hard copy, so me as a program also when I request. When you say request, a vision, yes. So when I request, it goes to the clinical pair. After the clinical pair, the second after clinical pair, HR goes to account. Account, that's when it's written. So DH now either authorizes or guides. So that's in the addition. But when it in addition fails, we are forced to go back to the hard code. So I will wait. Then sometimes the clinical care or the planner will verify the availability of those funds and then basically that's what that at the end of the clinical care when the program right. So usually for 8 hours after that.
No, it's muted.
people, we need to discuss, please.
This is
Yes, thank you.
from Sesheke DHL.
Okay, thank you.
Yeah, I think another addition would be that the young single mother will need support, psychological and also financial support.
Okay, how would we offer financial support in this case?
There are some IPs that provide material economic support to MDR patients. I don't know if that works in Southern Province as well.
Okay.
Yeah. Then we did not hear anything about the father of the child in this case. Are we assuming that he is also young and unsupportive or unable to support, because he's also another source of even psychological support for the young mother?
Yeah, looks like the role of the father is very limited. If the father is there, we'll need to get him on board. But if not, we work with the family that is available. So it
Yes,
looks
and
like since, like you
speaking
said,
of the available family, this is not a child-headed family, though it did not come clearly it didn't come out clearly who the head of this family is. But I think that person should be more involved, considering the mother of this our patient is really also a child.
okay, yeah, that is true. Okay, thank you very much for that one. I just wanted to make a contribution also on the drug-to-drug interactions. This is a child who, hello? Howard?
Yes, this is Howard. As you
Yes,
make a contribution for number 2, I think quickly you can just also make a contribution for number 6, because we may log out anytime.
Okay.
So just wanted to keep on time.
All right, okay. So on number 2, remember the child was primarily on a lopinavir-based regimen, and lopinavir with rifampicin, which the child was on previously, will interact, and the lopinavir will actually be, you may need to make some dose adjustments or actually change the regimen to give something that is more friendly, child friendly. So this, I think we're moving in 2 minutes. So quickly, it's possible that the rifampicin and the lopinavir interacted and actually reduced the lopinavir such that, and that could have contributed to the treatment failure in this child. So we need to be wary about the drugs that we give. But thankfully, on the other regimen that was prescribed for drug-resistant TB, with the lopinavir and the ABC, 3TC and lopinavir, there are no drug interactions for the second line treatment. Then quickly on the TPT considerations, we do not have a standardized TPT regimen for drug-resistant contacts. However, when you have a drug-resistant contact and you want to give TPT, it has to be in consultation with the national clinical team for TB. And what is going to be considered when coming up with a regimen is which drugs the patient is actually which drugs the index is actually sensitive to. So if, for instance, there's levofloxacin, which is sensitive, then you can actually put a TPT regimen, which is just levofloxacin. Okay, so those are some of the considerations. So you need to have in mind the sensitivity of the index case for the DRTB. I think we don't have much more time. We will break out. Thank you so much. I hope we learned 1 or 2 things from this discussion.
Thank you very much, Doc.
Good afternoon, network. Welcome back. I think that was a very, very interesting case, and I hope you had some fruitful discussions in the breakout sessions. We've totally run out of time, and we do not want to keep people on the call anymore. But I hope you've had very fruitful discussions with the experts in the breakout sessions. But I will allow Dr. Lungu just to summarize some of the concerns and the questions that came out of these discussions. And we hear from him, and then we hear from Dr. Chanda if he's happy with these recommendations that will come out from this session. Dr. Lungu.
Thank you very much, Chair. The privilege to join the Lusaka group and the very, very fruitful discussion. I think the Mazabuka team should be commended for the great job done. I know Mputu as well from the national level did provide support in this challenging case that Mazabuka just shared with us. So ladies and gentlemen, join me in congratulating and also commending Mazabuka for this case. The battle for sure is not yet won for the cases in Mazabuka. They have got a lot of work to be done. But I think, Chair, in the shortest period of time that I have, I would like just to press emphasis that contact tracing must be done for every DRTB patient. The chest X-ray should be utilized in the screening, and we should also endeavor to collect very good sputum in these patients. And now for the cases, for challenging cases such as childhood TB presumptive cases, we could also use stool. And also just to emphasize that a good clinical argument is key to everything that we are doing. We should expose our sputum and other specimens to a culture for us to totally confirm and exclude TB. Where you have challenges collecting a very good sputum, ladies and gentlemen, you could do a sputum induction. We have bought sputum induction machines that we are distributing to a number of facilities. So please utilize those modalities. The other issue that I would like just to emphasize is the TB HIV management in patients with any form of TB. We need to optimize the care for ART. I think those are the key elements, Chair, I wanted to just emphasize on. And then also where we have challenges, please consult. There are various experts in the provinces and also at the national levels that are ready to provide the necessary support. A case that was shared by Mazabuka, I think, has brought quite a lot of lessons. When you see a TB patient in front of you, there are multiple TB patients behind that particular patient. Chair, I'd like to thank the entire network and yourselves for organizing this meeting. I end here.
Thank you very much, Dr. Lungu. We do appreciate and we thank you for that summary. And I hope this answers some of the questions that the network may have had over this case. And so just one more question. As part of IPC, and all policy regulations, what happens to MDR-TB patients who are smear positive and the interaction with the rest of the community? Dr. Lungu.
Yeah, so thanks, Chair. One of the things that also I forgot to emphasize on TPT. So previously, ladies and gentlemen, we used to keep MDR patients in admission for a prolonged period of time. Yeah, and we thought it was the best of care. And those of you who worked at UTH will agree with me that patients were jumping off E-block in an attempt to commit suicide. And one of the things that we have realized that immediately you put these patients on treatment, they start to sterilize almost immediately. So what is just critical is that the patients must be on treatment. As you learned from this case, the people who are mostly at risk are the household members. And by the time we are diagnosing this patient, they're already infected. So it did not serve much purpose to admit this patient unnecessary. What we should just emphasize is that all their close contacts are adequately screened, they are put in treatment. We are still admitting some, but now admission is reserved to the acute, to those with acute medical conditions, and those where we cannot guarantee or where we have excluded that the children are negative. So we will ensure that by the time the adult is discharged, we have sterilized and also put the other family members on TPT. The other modalities that we just need to encourage our patients is the wearing of surgical masks. Previously, I think for us as a TB program, we have found an opportunity in the advent of COVID. This is something that was quite challenging to push the community and DRTB to put on a mask. Now it's uniform. So what we could emphasize that when these individuals are walking around the community, they should put on a surgical mask. Those are the masks behind. Chair, I mentioned that I did not talk much about TB preventive therapy. This is one form that we should optimize in context of DRTB. So even in context of DRTB, we can provide TB preventive therapy. At the present moment, our fallback plan for TPT in DRTB is the isoniazid. What we could do for isoniazid is that we need to know the resistance pattern or profile of the index patient. If in an event they have high resistance to isoniazid, then we could look at other modalities such as deranamide, combining it with ethambutol, or combining with PZ or levofloxacin as a single TB preventive therapy. But by and large, isoniazid will still be effective in DRTB contexts. So I'd like to encourage everyone to start moving in this direction. Where you have challenges making a decision, call the national CEC, the provincial CEC, or the national TB program.
Thank you very much, Dr. Lungu. I think Mazabuka has shown us the way that we need to co-manage these patients on the ground, as well as experts getting involved in the early stages. Then we can quickly intervene and protect our community. So I think with that said, I want to just say thank you very much, Team Mazabuka. And Dr. Chanda, are those recommendations for your further management of a patient something that you think you will help you?
Hello.
Yes, Dr. Chanda.
I would like to thank everybody who has participated in this case, both the team here at Mazabuka and at the district level. Also for everybody in the network for giving us all those suggestions on how we can improve management of this family. We've been taking notes, so everything that has been shared, we've written it down, and what we can do, follow through, and what we can't do, we'll be calling the experts that always available and helping us. So we thank you for that.
Thank you very much. I think this is where we end our session. Thank you for hanging on for a few more minutes beyond our timing. Have a good day.